Well, it's really my pleasure to welcome the Poudre Valley Family Medicine team. Chosen quick, a few of our steering committee members had the pleasure of visiting this group and did our first post-COVID site visit. And the other first was that it was the first time we visited a group in the outpatient setting. Isn't that amazing? Like, we started Chosen Quick in 2017. It was the first time that we engaged with outpatient providers, those that are working with our families either before or after birth hospitalization, in this instance, all throughout that perinatal spectrum. And so we were delighted, astonished, so encouraged by what we heard that we knew we had to bring the team here so that you all could hear about the terrific work that they're doing. And in many ways, it's a perfect segue into the workshops, where you're going to see what an ideal model could look like and how we start to address those various key drivers that I highlighted at the beginning of the day through this type of care model. And you're going to learn about each of those key drivers in the workshops, but this is what it could potentially look like when put together. So really, I'm thrilled to welcome Monica Faherty, Robyn Gustafson, and Courtney Kuepper, and Jeannie Folan. I'm going to have them introduce their roles and themselves so that I don't take more time away from them.
Hey everyone, thanks. It's so nice to be here. We are very excited to share with you. We'll start with a couple introductions. I'm Jeannie Folan. I am a family physician faculty at the Fort Collins Family Medicine Residency and at the Fort Collins branch of the CU School of Medicine.
I'm Monica Faherty. I'm the OB care manager and lactation consultant at Family Medicine Center and Poudre Valley Prenatal.
I'm Courtney Kuepper. I am a social worker at Family Medicine Center.
And I'm Robyn Gustafson. I'm the advanced practice nurse for Women and Children's Services for UC Health North. So I cover 4 different hospitals, and you'll hear about what I'm working on later. Let these guys take over the show.
So we're going to talk a lot about what we do and all of the different aspects of how we care for birthing people and their children and their families. But I just wanted to start with sort of framing it in this idea of family medicine, which I feel very grateful to be in the field of family medicine. This is a quote from sort of the history of where family medicine comes from. And I just want to highlight the idea that at the forefront of what we do is the relationship with not only the patient who's in front of us, but also their environment and the people who are around them. And so the example that I'll give you is that maintaining a relationship with a birthing person gives me so many opportunities outside of that person's care, including vaccinating their child, caring for their father's diabetes, helping a grandparent choose hospice. And so that's sort of the beauty of what we're able to do. And I just want to drive home that we love family medicine. The residency program, so PVH and FMC are house our training program for 8 residents per year for a 3-year family medicine residency. It is truly full spectrum family medicine. So we are training residents receive rigorous training in outpatient and inpatient adult, pediatric, and obstetric care, including about 90 deliveries through the course of their residency. We also have a number of other services that we provide our patients, including medication abortions up to 11 weeks and buprenorphine specifically treatment for addiction.
And within our clinic, we have 2 clinics that provide OB care. Family Medicine Center is staffed with residents and faculty physicians. Each provider has a set OB panel where they care and they follow throughout the patient's pregnancy, delivery, and postpartum care. These physicians ideally will care for the newborns as well. We strive in both sides of our clinic to have continuity of care and assign each pregnant patient to one provider and then have a second provider available as backup. Poudre Valley Prenatal is our second clinic. That is our high-risk OB clinic that is staffed with an OB attending that's from one of the local OB groups within Fort Collins. And every 2 weeks, the residents rotate through and are provided with an intense learning environment to master their OB skills. These patients and their newborns will then transition over to the family medicine side after delivery for newborn care, as well as primary care after the 6-week postpartum visit with Poudre Valley Prenatal.
a large part of our clinic is an integrated behavioral health team, which I am a member of. There's about 7 of us that rotate through the clinic, 3 social workers that focus on our OB patients. Before they even meet with a medical provider, most of the time, they'll sit down for a full psychosocial intake with one of the social workers. We get 40 minutes instead of just the 20 with them, where we get to screen for mental health needs, substance use, trauma history, get a really big, full picture of life outside of their pregnancy, life outside of their medical health, because we know that that influences their physical health too. And that's exactly how I explain it to patients. I think this conversation lays a foundation for all of the work that we do in the clinic, for open communication and building relationships. It very often, I will get an answer that is different than what they will tell Dr. Folan. But I think that's really lovely because it gets people thinking. And I love that we're just opening those doors to conversation. So we do ongoing case management of our OB patients, resource referral, connection to anything that they might need. We are looking towards doing some work around plans of safe care. So I'd love to have more conversations with people on that. And we have really open communication with our inpatient team at Poudre Valley Hospital. So we are able to communicate with the nurse navigators there, the social workers there, anytime our patients pop over to the hospital. And we all use Epic, so all of our documentation is the same, and we can see that across the board. Yeah.
I could sit here and talk for hours about the incredible work that many people are doing as far as buprenorphine treatment through our program. There are 2 options that patients can utilize to get buprenorphine in within our clinic. One is housed in the clinic. It is a little bit more case managed. It is only open to people who are established patients at FMC. The other one is a resident run clinic, which is run in conjunction with the Northern Colorado Health Network. NCHN is a incredible group of people doing harm reduction in the community. And so this is where a lot of patients have been getting their syringe access programs and their screening for HIV and hepatitis C. And so we go to that place, and the residents run an incredible clinic there and provide buprenorphine for many people in our community. Both of these clinics are focused on being low barrier and are focused on harm reduction. And the example that I'll give you for this is that we screen patients for the use of buprenorphine. So we do an every 3-month urine screen confirming that they are taking buprenorphine, but we are not doing urine drug screens that screen for all sorts of illicit drugs. And part of this is that we don't want any reason to remove someone from our clinic. It's really, really hard to get kicked out of one of these clinics because we are just not looking for those things. And it allows our patients to really openly and honestly talk to us about other substances that they might be using, any relapses that they've had. And I think that many of us who work in the space find that the fact that we are not doing anything that makes a patient feel like they're going to get caught in a lie actually really allows them to be more open and honest with what's going on in their lives. The example of a recent success that I will give you all is a patient who presented to the OB/ED with little or no prenatal care at 30 weeks with active fentanyl use. She delivered via urgent C-section. The baby was cared for in the NICU. Mom was cared for by our resident team and induced on buprenorphine during the hospitalization. She and baby are both continued to be patients in our clinic, both for their postpartum, buprenorphine, and newborn care. And so that's a really amazing story that we've been able to just coordinate her care and sort of keep her in the family, which has been really nice.
So how we handle drug of abuse screens in our clinic to test or not to test. It's really a shared decision-making process, which is a newer process for us in our clinic. We used to have a policy of doing UDOA as all those acronyms just really get just in my brain. At 24 and 32 weeks gestation with informed consent. And now we have scrapped that, and it is very much a shared decision-making process between provider and patient. So just as another example of a real patient, we have Katie, which I think is funny because it sounds like Katie, but that's not her name. Katie, a patient with a significant history of polysubstance abuse, including methamphetamine, and a positive toxicology in the first trimester prior to learning of pregnancy. She also has a significant history of mental health concerns, housing insecurity, a previous child that was removed from her care about teens of years ago. So based on this history, we are assuming that a CPS referral is very likely going to happen when baby is earthside. So patient and provider engaged in a conversation around what toxicology testing might look like during pregnancy. And Katie opted to do toxicology testing every time she is in clinic and establishing a pattern of having no methamphetamine in those so that the inpatient team will be able to see that as well. So that was a decision that she and her provider were able to come to together. And we have other patients that do that, and we have other patients who don't want to do that. And we just support them in whatever decision they make. Okay. You have it.
She has all of the pattern. So what about breastfeeding and lactation? While we all acknowledge that there is a risk of using THC while breastfeeding, we all acknowledge the benefit of providing breast milk to our infants, and we all want to advocate for our patients to do what feels best for the birthing parent and for the newborn. Within our clinic and at the hospital, we provide education, community resources, and we allow lactation support to these dyads in the well newborn setting during inpatient and outpatient postpartum care. The discussion of substance use and breastfeeding begins at the OB intake and continues on throughout the postpartum period. We all strive to have open communication with our patients and want them to feel like we are supporting them in their decisions. Providers, when rounding on our patients in the hospital, continue the conversation of breastfeeding and substance use. They have a strategic and designated dot phrase that is used among our providers to streamline the conversation. Through shared decision-making, patients are allowed to breastfeed and obtain lactation support in the hospital because of this shared decision-making and open communication between providers, patient, nursing staff, and the lactation team. We then carry this feeding plan in the outpatient world with help from our postpartum support group. Courtney and I have created a weekly postpartum support group where anyone caring for an infant under 1 year of age can attend. We provide lactation support, feeding support, and education regarding care of infants and toddlers. No topic is off of the table at this group. What once was a group of 2 has now transitioned into a group of 14 dyads, plus support people, plus toddlers. And starting this week, we're going to transition into a bigger space. We also encourage peer support and relationship building. We offer community resource referral and provide necessary care items for caregivers and their infants. The residents will also begin to attend within the next month or so to gain more hands-on experience with providing community education, as well as feeding support for these infants.
And just a few little examples of some of our lovely caregivers that come that we're able to connect with resources. We have a food bank in our, I don't think we discussed this. We have a Larimer County food bank location in our clinic that's called the food pantry. And so we are able to connect patients with that. One gal and I just went over after group and got her set up and sent her home with a box of food. And now on Wednesday, I peeked outside my office and I saw 4 of our moms like just waiting in line at the food bank to get their box of food right after group. So that's just an example of how we are connecting people to resources in that community, and they're all chit-chatting and getting their boxes of foods, and it's really quite amazing.
Okay, I'm out. So I want, there is a hospital piece. Most of our patients come to the hospital to deliver. So we want to kind of focus on how can we bridge that gap between the amazing prenatal care that they're getting in these clinics and the care that they're going to continue to receive after delivery when they're in the hospital. And so just a little bit about PVH. We have about 1,800 births a year. We have an OB-ED unit, a separate L&D unit, a separate postpartum unit, and we do have a 35-bed level 3 NICU that includes 25 private rooms. 2 of those are twin rooms and 1 is triplet. So especially for those patients that do have active substance use, the baby does need to end up in the NICU. A private room that allows rooming in non-pharmacological care is really the best supportive environment for those patients. PVH is part of UC Health. And within UC Health, it's part of the northern region. And so those 4 hospitals are Poudre Valley Hospital in Fort Collins, Medical Center of the Rockies in Loveland, Greeley Hospital in Greeley, and Yampa Valley Medical Center, which is in Steamboat. One of the things that we have had in place, and it's always evolving, but for a number of years, especially as we first joined Chosen back in 2017-18, is our prenatal consult appointment. So when a patient is ideally identified in the prenatal period, having substance use disorder or a history of substance use during pregnancy, they can be referred by the lovely outpatient team to our inpatient nurse navigator. And ideally, she meets with these families around 34 to 36 weeks gestation or whenever really identified. This visit can include the nurse navigator, our in-hospital social work, as well as our developmental care team. And really at that appointment, they discuss what to expect in the hospital, non-pharmacological care, depending on the substance exposure, eat, sleep, console, how the baby's going to be assessed, that sort of thing. We also really focus on catching the gap. So what services have they already been enrolled in prenatally? WIC, HCP, and then anticipating EI referrals, that sort of thing. So the family knows what to expect, and also, again, catching some of those other support services that they could be pulled into. We also talk about shared decision-making, again, around the care of the child or the infant, and then lactation, that sort of thing. And we're in the future, our nurse navigator is really hoping to formalize and add some peer support at all of these visits as well to help support the families. There you go. Perfect. Thank you, Jeannie. And then this is kind of the boring part of it. Like what they're doing is exciting. And with the patients, this is sort of that work in progress behind the scenes and the quality initiative is, and this is really where my job is. And so our PVH North region participates in so many of these state level collaboratives, and we're really working towards adapting and adopting these recommended best practices at the hospital level, the regional level, and then also at the system level of UC Health. And so one of the examples, and actually one of the small groups, is Dr. Christine Gold, who's focusing, I think, on writing that toxicology testing policy. And so she and I are working together to get that moved forward at the UC Health system level that will hopefully then provide that same standard across UC Health that will help support some of the great work that's being done in a very local level as well. And through that adapting and adopting, what that kind of looks like is reaching hospital, regional, and system level consensus, which is challenging, as we all know, in lots of ways. Again, the boring part of that is updating or creating policies, workflows, and order sets that help support what that new best practice recommendations are. Implementing new programs such as the OB-ED and postpartum naloxone distribution, which hopefully most of UC Health will be on board in with the next 4 to 8 weeks or so, or potentially by the end of the calendar year, we will hopefully all have that in place across our system. And really what it is about sometimes challenging the status quo, addressing bias, judgment, and advocating for shared decision-making for all patients, regardless of their history. So that's kind of how the hospital side is. And then we hand them back over to this lovely team who continues to foster that as they move through raising their children. So.
Isn't that amazing? I mean, isn't that what we're all trying to do? I just regret not having met this lovely group 6 years ago. It just tells you how siloed we are in this state. Everyone's doing lots of great work and we still don't yet know about each other. We have time for a couple questions. Any questions, burning questions? The one question that I always comes to mind is sustainability. How do you all fund this? Like, who pays for this? Is this covered by insurance? Or do you have like a magical pot of money in the hospital?
Yes.
I know. I don't know that I'm totally qualified. I think that frankly, some of it comes from the fact that we get a bit of forgiveness being a residency training program. And also from really incredible driven learners who are willing to put in a lot of work to create a system of more equitable care. I don't know that I have a better answer than that. And we bill for things.
Have also a group of incredibly passionate people who love these families. And I think that's sort of what you all are getting at. Yeah.
Yeah, we got a grant to start a postpartum support group,
Okay.
through C-ONQS. And then there's also the PEDS group.
So it sounds like there was some grant funding, perhaps some seed funding to kind of get this going. And then clearly you have champions in the hospital that continue the work. But really, when we move towards sustainability and how do we make systems level structural changes to allow this to continue and really disseminate throughout the state, we have to think broadly about at the policy level, at working with other organizations. As a neonatologist, I can't do what you all do living in the NICU, right? So there clearly has to be collaboration for something like this to actually be disseminated to other clinical care areas. So thank you so much.